When your patient in respiratory distress, time is critical, but you've got options: CPAP, BiPAP, AVAPS, high flow nasal cannula, and HVNI. So how do you know which one to use? In this video, I will walk you through real clinical scenarios to help you match the right mode to the right patient. Let's go. Mechanical ventilation can be invasive with a tube or non-invasive using a mask or nasal interface. That's where NIPPV comes, non-invasive positive pressure ventilation. Under the non-invasive positive pressure ventilation, we have 5 main tools: CPAP, the continuous positive airway pressure; BiPAP, bi-level positive pressure ventilation; AVAPS, average volume assured pressure support; HFNC, high flow nasal cannula; and HVNI, high velocity nasal insufflation, or what we call commonly vapotherm. Now, because non-invasive positive pressure ventilation relies on patient cooperation, it's not for everyone. You should not use it in patients who are severely confused, severely agitated, persistently vomiting, have facial trauma, or copious secretions. In short, if they cannot protect their airways, it is not safe to use non-invasive positive pressure ventilation. In those patients, we should proceed with endotracheal intubation instead. Let's start with the first clinical scenario. A 68-year-old man with severe COPD comes in with worsening shortness of breath and productive cough. He was tachypneic and mildly hypoxic, which was corrected with 3 liters per minute of nasal cannula, and he was hypercapnic. PCO2 in ABG was 68, pH 7.28. He is confused but still follow commands. Chest X-ray showed hyperinflated lungs without vocal consolidation, and despite bronchodilators and steroids, his work of breathing still high. So clearly this patient has COPD with acute exacerbation complicated by acute hypercapnic respiratory failure. Now, along with medical treatment, how do you think we can help this patient's work of breathing and hypercapnia? Now, this patient obviously primarily needs help with ventilation, CO2 removal, not oxygenation. The mode of choice here is bi-level positive airway pressure. In clinical practice, it's often referred to as BiPAP, which is actually a brand name of one of the machines that providing this mode, but it's commonly used interchangeably here. But hold on, wasn't the patient confused? Important here, confusion is not an absolute contraindication to use non-invasive positive pressure ventilation as long as the patient is cooperative and following commands, able to protect his airways. It is safe to try the NIPPV. Now, think of BiPAP like pressure support mode in mechanical ventilation. It delivers a higher pressure during inspiration, the IPAP, and a lower baseline pressure during expiration, called EPAP. Now, the difference between the IPAP and EPAP drives ventilation and CO2 removal. The higher the difference, the more ventilation and CO2 removal. EPAP value in the BiPAP mode is equivalent to PEEP in mechanical ventilation in the pressure support or pressure control modes. It is the baseline pressure that's present throughout the respiratory cycle, and IPAP is added on top of it during inspiration to drive ventilation. Now, EPAP and FiO2 are the two values to play with to improve oxygenation when using BiPAP. When ordering BiPAP, you will need to specify 3 key settings: the FiO2, the inspiratory pressure, the IPAP, and the expiratory pressure, the EPAP. Take a look at this BiPAP screen. The IPAP is set to 18 centimeter H2O here. The EPAP is set to 10 centimeter H2O, and FiO2 is set at 80%. The peak inspiratory pressure reads here 18 centimeter H2O. And here is something critical to understand. Not all BiPAP machines define the IPAP the same way. Some calculate IPAP above the EPAP. So if the EPAP is 10 and IPAP is 18, your peak pressure is 28 centimeter H2O. Other, like this one, treat IPAP as the peak inspiratory pressure, so it's just 18. This matters when adjusting for tidal volume. Always know how your machine defines IPAP. Also, check out, there is a backup rate here set to 18 breaths per minute. Now, while BiPAP usually relies on patient triggered breaths, most machine now includes a backup rate to guarantee a minimum number of breaths even if the patient stop breathing or become apneic. Now, remember, the values at the top are the actual values including including the actual tidal volume the patient is pulling and the amount of leak, and the bottom values are the set values. Now, a quick note about the leak on this BiPAP or on BiPAP. All BiPAP systems are designed with a certain amount of intentional leak built into the circuit to prevent CO2 rebreathing. The exact amount of this intentional leaks varies by the manufacturer and device design. In contrast, unintentional leak refers to unwanted air escape, usually from poor mask seal or mouth opening. And what you see displayed on the machine screen here is the total leak, which is the sum of both intentional and unintentional leak. And there is no universal standard for what leak rate is acceptable, since it depends on the specific device and the specific mask interface. However, if the leak becomes excessive, it can lead to under delivery of tidal volume and ineffective ventilation. Pay attention, a sudden increase in leak without any change in pressure settings should raise concerns. In such cases, ask the respiratory therapist to refit or replace the mask and closely monitor the leak amount. A common starting point when I use BiPAP, IPAP of 10 centimeters 2.0 and EPAP of 5/10/5 or 15/5 in brands that interpret IPAP as the peak inspiratory pressure. From there, you can adjust the IPAP, EPAP gap to achieve your target tidal volume. Now, back to our patient, you ordered BiPAP 10/5 and FiO2 50% and a backup rate of 14. The patient was already breathing around 22 breaths per minute, and you told him to repeat ABG in 2 hours. Of course, you got busy with other things. The next ABG comes and showed not much change in the pH and CO2 level. And finally, you had a chance to look at the BiPAP screen and notice that the patient was barely pulling almost 300 cc of tidal volume. That's why you should always take a moment to look at the patient's BiPAP screen after making any changes to see how much tidal volume they are averaging with each breath. At that point, you decided to increase the IPAP to 15 and immediately noticed that the tidal volume has improved to almost 400 cc. Your respiratory therapist asks you if we should switch the patient to AVAPS mode. So what's the AVAPS mode? Before that, if you would like to receive a summary of this video, kindly subscribe to my Substack page. The link is provided below. AVAPS, average volume assured pressure support, is a special mode of BiPAP itself that adds a key feature. It automatically adjusts the inspiratory pressure IPAP to achieve a target preset tidal volume, and is similar to the PRVC mode, pressure regulated volume controlled in invasive mechanical ventilation. And here I highly recommend you check out my full video on invasive mechanical ventilation. I will leave the link below in the description field. Now, many of you probably have heard about Trilogy machine, which is sometimes used interchangeably with the AVAPS mode. But to clarify, Trilogy is just a brand name. It is one of several devices that offer AVAPS mode, not a mode by itself. When ordering AVAPS, we need to provide the following values here: the FiO2, the target preset tidal volume that we're trying to achieve, the minimum and maximum IPAP range to adjust to deliver the preset or desired tidal volume, provide EPAP, which is equivalent to PEEP, and provide a backup rate. So you figure it's smart move to switch your patient to AVAPS mode with a target tidal volume of 400 cc, EPAP of 5, minimum IPAP of 8, maximum of 25, FiO2 50%. Now you can rest assured that the patient will get this tidal volume. AVAPS can be used in most situations where BiPAP is indicated, including both acute and chronic settings. Common uses including COPD with hypercapnic respiratory failure, whether acute or chronic, central sleep apnea, obesity, hypoventilation syndrome, and neuromuscular disorder like ALS and myasthenia gravis. Take a look at the AVAPS mode screen here. You will notice settings for maximum and minimum IPAP, value of EPAP, target tidal volume, and the backup rate. And remember, the values displayed at the bottom represent your preset settings, while the numbers at the top reflects the actual delivered values in real time. Keep in mind that the ventilator aims to achieve the preset targets, but the delivery delivered values may not match them exactly. They will be as close as possible based, of course, on patient's effort and respiratory mechanics. Then you got called again back about an hour later because the patient keeps removing the mask, saying he can't tolerate it anymore and refuses to wear it no matter what. So what's your next move? Fortunately, the HVNI, high velocity nasal insufflation, is shown to reduce CO2 level and improve pH in COPD exacerbation with a similar rate of success as BiPAP. So what's HVNI, high velocity nasal insufflation? It's a type of high flow nasal cannula that delivers high flow rates of warmed humidified oxygen through small, very important, small nasal prongs that generate a high velocity jet of air in the upper airways. This helps wash out anatomical dead space and provides a modest CPAP or PEEP-like effect. These two effects help ventilation and oxygenation without requiring a tight-fitting mask. Now, the term vapotherm has been used interchangeably with HVNI, but to clarify, vapotherm is a brand name of the device that exclusively provides the high-velocity nasal insufflation technology. Now, when ordering vapotherm, you need to specify both the FiO2 and the flow rate. The maximum flow rate with vapotherm is 40 liters per minute, which produces an estimated CPAP effect of around 6 to 8 centimeter H2O. Now, generally, the higher the flow rate, the more effective it is for oxygenation and CO2 clearance. Now, back to your patients, you place order to start him on vapotherm with FiO2 50% and flow rate 40 liters per minute. And 5 minutes later, your respiratory therapist called you to let you know that unfortunately all vapotherm devices are currently in use, but they do have a standard high flow nasal cannula device available. Can she use that instead? Now, how do high flow nasal cannula devices differ from vapotherm device? I will discuss that soon in this video, but for ventilation and CO2 removal's sake, high flow nasal cannula is not as effective as vapotherm, although it can be used if no other alternatives. So for our patient, he's refusing to wear the mask and vapotherm is not available. In this case, high flow nasal cannula device can be tried as an alternative. However, we must explain to the patient, if feasible, or his family, that high flow nasal cannula may not be as effective and we may ultimately need to proceed with intubation. Let's move to a new clinical scenario. A 72-year-old man with a history of heart failure with reduced ejection fraction presented to the ED with acute shortness of breath. He's tachypnic using accessory muscles and his O2 sat was 82% on room air. A chest x-ray reveals bilateral pulmonary edema or infiltrate suggestive of edema. ABG showed PO2 52 mm Hg and PCO2 of 30 mm Hg. In addition to medical therapy for his pulmonary edema, how would you help this patient with oxygenation and work of breathing? So as you see, the patients primarily need support with oxygenation. Continuous positive airway pressure or CPAP is the preferred mode in cases like this, like pulmonary edema, or when hypoxia is driven mainly by alveolar collapse and de-recruitment. CPAP improves oxygenation by preventing alveolar collapse and de-recruitment and reducing preload and afterload by increasing intrathoracic pressure. It does so by delivering a constant level of pressure throughout the entire respiratory cycle. This CPAP pressure is equivalent to the PEEP in mechanical ventilation or the EPAP with BiPAP settings, with BiPAP mode. Very important, CPAP does not affect ventilation or CO2 removal. It does not help with that. Now, when ordering CPAP, you should specify FiO2 and the CPAP level in centimeter H2O. Back to our patient, you order CPAP at 10 centimeter H2O with FiO2 100%. Now, if the patient remains hypoxic, you can increase the CPAP in increments of 2 to 3 centimeter H2O or 2 to 4 while closely monitoring for tolerance and hemodynamic effects. As the patient improves, be sure to wean FiO2 promptly, aiming to reduce it to 60% or less as soon as clinically tolerated to minimize the risk of oxygen toxicity. Once the FiO2 requirements is equal or less than 60%, you can begin weaning down the CPAP level itself, typically in small increments while monitoring for signs of decompensation. Remember also that CPAP is the cornerstone of treatment for obstructive sleep apnea, not central sleep apnea, for obstructive sleep apnea. Now, when they come to the hospital, if the patient has their own home CPAP device, I typically encourage them to use it. It's more comfortable and familiar than hospital-issued machines. Let's take one last clinical scenario. A 56-year-old man with no significant past medical history presented with fever and productive cough along with shortness of breath. He's febrile and in moderate respiratory distress. Oxygen saturation 86% on 6 liter per minute via nasal cannula. Chest x-ray showed dense right lower lobe consolidation suggestive of pneumonia. His pH was 7.45, PO2 was 52, and PCO2 of 38. Now, in addition to initiating antibiotics and supportive care, what is the most appropriate strategy to help this patient oxygenation and reduce his work of breathing? Your respiratory therapist suggests starting CPAP at 10 centimeter H2O with 100% of IO2, and at the same time, the ER nurse told you that the patient oxygenation saturation has improved to 95% on 100% non-breather mask, and she questions, why do we need CPAP? Now, here's how I think about it. I always lean toward the most effective therapy, and if two options are equally effective, I choose the one that is better tolerated by the patient. In this case, CPAP, vapotherm, and high-flow nasal cannula are all reasonable options. They offer better support than conventional oxygen therapy like the non-breather mask, and not just by improving oxygenation, but also by reducing the work of breathing and lowering the risk of intubation. That's why sticking with a non-rebreather alone is not ideal. It's not a good strategy here. The non-rebreather again improves FiO2 but does nothing to offload the patient's work of breathing, which is a key target when managing these patients. Now, both HVNI, high velocity nasal insufflation vapotherm, and high flow nasal cannula tend to be more comfortable and equally effective compared to CPAP in this case at this stage. Very important, at this stage. And we previously talked about the HVNI and high flow nasal cannula in this video. Let's discuss the differences between these two tools. Now, vapotherm or high velocity nasal insufflation, as we said, is a therapy that delivers gas at high velocity through a narrow bore nasal cannula. The key idea behind this is that this will produce jet-like velocity of the gas that help flush out CO2 from the upper airways more efficiently by clearing dead space. So in addition to improving oxygenation, vapotherm actually provides some ventilatory support and CO2 removal, as we explained earlier. On the other hand, high flow nasal cannula delivers oxygen at high flow rates, while the maximum vapotherm 40 liter here can go to 60, 70 sometimes liters per minute through a wider bore cannula. Small bore cannula there, here's wider bore cannula. So it's an excellent choice for improving oxygenation, but it's less effective in CO2 removal, as we explained. It does not provide the same degree of dead space washout compared to vapotherm. Now, both therapies are well tolerated, far more comfortable than a face mask of CPAP, and both generate the same level or degree of PEEP or CPAP effect, which helps keep alveoli open. Now, in summary, both helps with oxygenation, but only vapotherm offers clinically significant ventilation and CO2 removal. Back to our patient, we started him on vapotherm at 100% of I2 and 40 liter per minute flow rate. These are the two key parameters you need to specify whenever ordering high flow nasal cannula or HVNI or vapotherm. Now, as the patient improves, I aim to wean the FiO2 down to 60% or less as quickly as tolerated, then begin weaning the flow rate only after that gradually. The next day, the patient was becoming more hypoxic despite maximum support with vapotherm 100% FiO2 and 40 liters. A repeat ABG showed that PCO2 is 38, PO2 is 55, and with FiO2 100%. So you repeated chest X-ray, which now showing development of bilateral infiltrate. What would you do next? It's obvious now the patient is developing ARDS. That's what it looks like. The patient is already max on vapotherm, and the patient should be escalated to CPAP to prevent further alveolar collapse and de-recruitment, which are hallmark of ARDS pathophysiology. A good starting point in this case is 100% of I2 and CPAP value of 14 centimeter H2O, in addition to prone position and steroids, of course. And as we just mentioned, CPAP is generally preferred over vapotherm and high flow nasal cannula when alveolar collapse and de-recruitments, widespread alveolar collapse and de-recruitments are the primary cause of hypoxia, such as in pulmonary edema, whether cardiogenic or non-cardiogenic. To wrap up here, there are 5 key non-invasive modes or devices commonly used in managing respiratory failure. We said CPAP, high flow nasal cannula, high velocity nasal insufflation or vapotherm, BiPAP, and AVAPS. And again, AVAPS is specialized nebulized mode of BiPAP. CPAP supports oxygenation only. It does not assist with ventilation. And the other four, the BiPAP, AVAPS, HVNI, evapothermic, and high flow nasal cannula can support both oxygenation and ventilation to varying degrees. In COPD exacerbation, vapotherm, BiPAP, and AVAPS are generally comparable in effectiveness. High flow nasal cannula, while excellent for oxygenation, is least effective for CO2 removal and ventilation. And when it comes to chronic hypoventilation syndrome, such as COPD with a chronic hypercapnia, obesity, hypoventilation syndrome, neuromuscular disorders such as ALS, and myasthenia gravis, BiPAPs and AVAPs are the preferred options. AVAPs in particular is helpful for patients with central sleep apnea, while CPAP is the mode of choice in obstructive sleep apnea. In the end, if you would like to receive a summary of this video, kindly subscribe to my Substack. The link is provided below. If you like what you watched so far, please give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. Thanks for watching, and see you soon.